Hello, I'm Dr. Jimmy Hu. Let's talk about some red eyes. I deal with the cornea and the anterior segment, and I'm practicing in New York City. Today, let's plan on reviewing the causes and diagnoses of red eyes, and then knowing when to refer. When evaluating an eye, it's always important to have a system. We typically go outside in. We're looking at the eyelids, the orbit, then the puncta and tear ducts, then the conjunctiva, the cornea, and then finally with the anterior chamber. Again, going from the outside in, there's a whole slew of possibilities here. And it's again important to have a systematic approach. You could have issues with the eyelids and adnexa, pathology within the orbit or the lacrimal gland system, a slew of issues with conjunctiva, corneal problems, and then there are others that are often even more serious but a little bit more esoteric, things like scleritis, uveitis, or angle closure glaucoma. When you see a patient who's got a red eye, it's important to have a systematic approach. Check their vision, look at the pattern of redness, check to see if there are any other findings, whether there's discharge, and if so, what kind. Check to see if there's chemosis, any pseudomembranes or membranes. Look at the cornea to see if there's any issues. And then stain the patient and see if there's anything else that gets highlighted. So let's go over a case. A patient comes into your office with itchy eyes. You take a look at them, the eye's a little bit red, there's a little bit of watery discharge. It's pretty bilateral, fairly equal in both eyes. You flip the eyelid and you find this. So what do you think? Well, let's describe it first. You've got some fairly vascular, reddish, cobblestoney, lumpy bumpy findings on the upper lid. What do you think that could be? So for the patient with conjunctivitis, let's distinguish between the two types. On the left here, we've got a follicular conjunctivitis. It's a reaction you typically find on the lower conjunctiva, and you see these rice-like little nodules in the bottom sac. It's really because these are lymphoid aggregates. There can be some vascularization, but that's not the classic hallmark. This is typically a reaction to either a virus or some kind of hypersensitivity. So in terms of viral causes, you've got herpetic issues, viral conjunctivitis like adenovirus reactions. We actually see this in COVID infections. You might also see it in chlamydia. In terms of hypersensitivity reactions, it can be a number of different things, but classically this is a reaction to brimonidine. On the right, we've got a papillary reaction. This is a classically non-specific kind of reaction that can be from any number of causes. You'll see it more commonly from allergies, a reaction to contact lenses. There's an association that's fairly well known with both keratoconus patients as well as floppy eyelid syndrome. You'll often see these prominent red cobblestone-like lumps. It's usually on the upper lid, and there's central vascularization. Okay, let's go over another case. A patient comes into your office with photophobia. You look at her, it's just in the left eye. You see these dilated, deep conjunctival and episcleral vessels They're a little corkscrewy, very tortuous, and they're all around the limbus. Looking a little bit closer, you might also see a little cell and flare in the anterior chamber. The cornea is otherwise fine. You just have a really hard time trying to examine her at the slant because she's so very light sensitive. What do you think that might be? So we often think of this as a ciliary flush reaction. Again, you see this injection of deep conj vessels surrounding the cornea, and again, it's going to be a ring around the cornea. You often think about this when you're dealing with causes of intraocular inflammation, things like anterior uveitis or even acute angle closure glaucoma. It's important to note that you don't see this in simple conjunctivitis. It usually implies that there's some ciliary body involvement. On the other hand, you've got conjunctival hyperemia when it's something more diffuse. You see engorgement of more superficial vessels. It typically starts from the fornix, and it's a very nonspecific sign. Generic conjunctivitis will often have hyperemia. All right, let's do another case. A patient comes into your office with mild photophobia, redness, and this non-specific irritation in the eye after spending a fun day at the beach, out in the sun. You take a look at them, and there's this raised yellowish growth on the conjunctiva. There's also a little injection around the area too. So this is another example in which you want to look at the distribution of redness. The image on the left here is a pterygium, and our example case earlier was that of a pinguiculum, and those can get inflamed after UV light exposure like a day at the beach. On the right side of the slide, we've got a more diffuse pattern of injection that typically goes along with other pathology. So when you're evaluating a patient with a red eye, it's important to ask about their history. How long has it been going on for? Do they have any pain, itching, discharge, changes in their vision, any sick contacts, any other associated symptoms that they've noticed? Do they have any history of allergy or atopy? And by atopy, I mean things like asthma, eczema, autoimmune issues. Ask about past disease, things like herpetic infections or a history of shingles. Ask about any other associated symptoms. Have they had a history of a sore throat or a cough? Have they had the sniffles recently? Do they have a history of contact lens wear? Do they sleep in their contact lenses? Do they have a history of glaucoma? And if so, what eye drops have they been taking? Have they had any history of surgery? Do they have any systemic diseases, autoimmune conditions being the big one, but also things like diabetes, Behçet's disease, lupus? Have they had any history of trauma? Or what do they do for a living? We often have a lot of construction workers who come in with red eyes, or researchers who have all sorts of occupational exposure. After a while, you start to learn that certain symptoms are associated with certain kinds of causes. If the patient's got itching in their eyes, you start to think about issues with the lid and conjunctiva, usually around the lines of allergies. If they've got pain, then you want to learn more about what kind of pain that they have. Is it a burning sensation? Is it pain in response to bright lights, at which point we call this photophobia? You start to think about other kinds of issues there. Do they have any kind of discharge? Is it watery or is it a little bit more crusty? Is it in one eye or is it in both eyes? Do they have a foreign body sensation? If so, how bad is it? Is it all the time? Is it worse in the morning? Is it worse in the evening? Do they have any kind of localized tenderness? And then there's all sorts of causes you start to think about that these symptoms might be associated with. A big part of it's going to be pattern recognition. So let's talk about some of the more common causes of red eye, like different types of conjunctivitis, subconj heme, corneal problems, especially the acute varieties, as well as anterior uveitis. There are different varieties and flavors of conjunctivitis: bacterial, viral, allergic, and chemical. Let's go over them. For conjunctivitis, it's often helpful to look at the discharge. Rarely you'll come across an eye that's got purulent discharge, at which point you'll often think of bacterial conjunctivitis. More often you'll come across a patient who's got clear white mucousy discharge, and you'll often think of more viral etiologies, or maybe it's an allergic reaction. Bacterial conjunctivitis is going to be more acute. You'll often find that it develops over the course of maybe 1 to 3 days. It's got a purulent discharge. You'll often have a pretty diffuse conjunctival hyperemia as well as chemosis. Bacterial conjunctivitis is going to be more common in kids. It'll often be affecting just one eye. Maybe after a while it can spread to the other because kids rub their eyes and they're not the most clean. It's often going to be pretty acute, and it's going to spread via direct contact with infectious secretions. We treat this with broad-spectrum antibiotics. It's important to refer these cases if they don't markedly improve within 3 days. And specifically because you want to watch out for hyperacute cases, things like gonorrhea. You'll have true membranes that literally bleed when you peel them off. And these cases, and I hope you never end up seeing one in your career, can get really bad really fast. They need to be treated with systemic antibiotics. But most cases resolve very well. Let's look at what you'll see a lot of over the course of your career. Viral conjunctivitis, at least the non-herpetic variety. This is highly contagious. This is the pink eye that we normally think of when people say they have pink eye. It usually starts in one eye and infects the other eye. There's often a history of recent contact with somebody else who's got pink eye. It will often itch. A person might feel a little uncomfortable. This is going to cause that follicular conjunctival reaction that we mentioned earlier. It's infective until tearing stops, and it's a reason to pull your kid out of school. And remember, this is a viral infection, which means that antibiotic eye drops do not help. You're giving them artificial tears, You can often tell them lid scrubs can relieve some of that itchy sensation, but really you're just trying to wait it out. Now, amongst the varieties of viral conjunctivitis, you'll often come across pharyngoconjunctival fever, or PCF, and that's really the triad of a sore throat, conjunctivitis, and fever. A person's going to come in with usually itchy eyes, some throat tenderness, and a fever. It can often last 5 to 7 days, and fortunately there's no permanent eye damage. This is often associated with an adenovirus infection. In terms of treatment, again, the most important part is just good hand hygiene. It's very contagious. It's a good reason to pull your kids out of school. Cold compresses, general eye care, some artificial tears, and really what you're trying to do is ride out the illness. This is a self-limited condition, and the prognosis is always very good. Alrighty, how about this case? A patient comes into your office with some eye irritation and blurry vision. What does that look like to you? HSV is always something to watch out for. They may or may not have a conjunctivitis reaction. They may have some recurrent episodes of it. Your patient's often going to come in with some non-specific symptoms of profuse watery discharge, maybe some photophobia. They may or may not have concurrent involvement of the eyelid with herpetic vesicles. Again, isolated cases where they just have corneal conjunctival findings can happen. The hallmark here is going to be your dendritic ulcer. They may have some stromal opacities. This is a very good case to refer to your local ophthalmologist. It's important to note that you can have involvement of the face and skin without involvement of the eye. And you can have other cases that involve just the eye, and you may not have any vesicles around the skin or eyelid. HSV is usually unilateral, it just involves one side. On the contrary, varicella zoster, also known as chickenpox or shingles later on, is often bilateral. Alrighty, how about this case? A patient comes into your office with a stuffy nose, tearing, and itchy eyes. Allergic conjunctivitis is something we often come across. Patients will often have an association with hay fever, asthma, eczema, atopic issues in general. It's often bilateral and seasonal. They'll have some mild conjunctival hyperemia and redness. They may have some mild chemosis. Itching is going to be your main hallmark. Importantly, it's not contagious, and it's often going to be confused with viral conjunctivitis, but a good history will help you separate that out. Also notably, again, on exam, a viral conjunctivitis will have follicles. Allergic conjunctivitis will have papillae. In terms of symptom relief, you're telling these patients to use cold compresses, artificial tears. You'll often give them a topical antihistamine as well as a topical mast cell stabilizer medication. A good one is Pataday that combines both. For more severe and recalcitrant cases, you'll often give them a short dose of mild steroids, often steroid-sparing immunomodulatory agents in really bad cases. A good example being cyclosporin like Restasis or Cequa. And you might even put them on some oral antihistamines. Okay, how about this one? A patient comes into your office because he woke up this morning with a red eye. That's right, it's just subconjunctival heme. It's just bleeding into the potential space between the conj and sclera. I often describe this as a bruise to a patient. It can be caused by trauma, medication, or even just having high blood pressure that may or may not be poorly controlled, and it usually resolves after a few weeks. It is important to refer these for evaluation if it's been recurrent, if it's been non-resolving after several weeks, or especially if there's a history of trauma and it's massive subconj heme, or even 360 degrees, because then you really worry about whether there might be some underlying injury or more extensive injury to the eye. Okay, let's do some cornea cases now. A patient comes into your office because he woke up this morning with a red, painful eye. He's got blurry vision, photophobia, and a history of contact lens wear. You look at the eye itself underneath the microscope, you see these fluffy little spots on the corneal surface. There's some localized corneal edema. There may or may not be a small epidefect. It's a little patchy. It's not quite clear, and the eye itself is pretty red. There may even be an inflammatory reaction in the anterior chamber. So this is your corneal ulcer. This is a pretty severe but localized infection of the cornea. It's most often bacterial, but it can be fungal or protozoan, the main one being acanthamoeba. This requires emergency referral to an ophthalmologist. You want to specifically note that there are infiltrates, these fluffy white spots on the eye that involve the stroma. A person's going to come in typically with pain, light sensitivity, a foreign body sensation, the eye itself is going to be red, and there's going to be this white fluffy opacity on the cornea itself. You may or may not have an AC reaction. You may or may not have a hypopyon. Alrighty, let's do another one. A construction worker comes into your office with pain, redness, and a foreign body sensation. You look underneath the microscope and you see this finding. What's this orangey red thing over here? It's in a circle. Yeah, that's right. It's rust. So this is your classic corneal metallic foreign body. And we see this with some regularity in New York, especially with all the construction that always seems to be going on. It's the kind of thing that develops after an embedded metal fragment, and especially if it's been there for more than 24 hours, it's going to start to form a rust ring. In this particular photo, it's been there for about 7 days, so the actual metal fragment itself has been fully oxidized. There's nothing left to remove. We typically treat these by sending it to your local ophthalmologist and having them debride and remove any embedded metallic foreign body. They'll also try and debride any rust if possible, because that's going to leave a scar if not removed. And you're putting them on prophylactic antibiotics because at the end of the day, in the process of removing it, they develop an epithelial defect, and you're trying to prevent any kind of secondary infection. You don't want them to develop a corneal ulcer afterwards. Alrighty, let's do another one. You remember this image. A patient comes into your office with mildly blurry vision and photophobia. These are the patients that you usually see in your office waiting room wearing sunglasses while indoors. When you look at them underneath a lamp, you'll find that they'll often have that ciliary flush reaction we discussed earlier. Photophobia is the big hallmark of how they're feeling, and it's because their pupil will often be myotic. It's minimally responsive, it's irritated, and so even with dilating drops, you'll find that these patients are slower to dilate, especially compared to the other eye. You may or may not see Keratoc precipitates, and these are little clumps of white blood cells stuck against the endothelium. You will certainly see cells and flare, and these patients are usually not going to be complaining of tearing or discharge. It's really going to be photophobia. That's the main hallmark of issues here. Okay, here's another one. A patient comes in after being hit in the eye with a baseball. You look at them underneath the microscope and you see this fine layer of red. So this is your hyphema, which is just a layer of pooled red blood cells in the anterior chamber. It's usually associated with trauma, and this requires emergency referral to an ophthalmologist for treatment. All right, here's another case. Last one, I promise. A patient comes in with eye pain, blurred vision, a headache. She's got a history of migraines. She's nauseous. She feels like she's going to vomit. She sees halos around lights out of the eye. You get her underneath the slit lamp. You see that there's, on a narrow slit beam, not a very deep anterior chamber. And then she's got a pressure in the mid-30s. That's right. This is the kind of patient you worry about acute angle closure glaucoma. It's really helpful to try and compare the anterior chamber depth of the two eyes. A narrow anterior chamber really suggests that it could be angle closure glaucoma. When in doubt, you can always do gonioscopy to suss it out. During an acute episode, they will have high intraocular pressure, but in some cases it can be intermittent angle closure, so bear that in mind. They can have normal eye pressures, but they could just be prone to having attacks of acute angle closure. These symptoms can often mimic a migraine headache. A lot of these patients will be hyperopic. It's also important to note that it can be exacerbated by certain medications. The classic one is topiramate, but a lot of the anti-seizure medications do fall into that category. This does warrant urgent referral to your local ophthalmologist. You're often putting them on some IOP lowering medications. And if you suspect that they're intermittently closing, then even just putting them on some prophylactic aqueous suppressants may even help. So just to wrap up, a few final pointers here. Listen to the patient's story, do a good thorough exam, go from the outside in, build a system for evaluating the patient. Look out for things like pain, pressure, photophobia. Make sure they don't have an infection. Look for things like an infiltrate. Pay attention to a history of contact lens wear. If you're worried about infection, you want to avoid steroids because that's only going to make an infection worse. And I can't emphasize enough, when in doubt, refer. We will always be happy to see a patient. If in doubt, call the office. We can always have a conversation about it too. Alrighty. So thanks for listening. I'm Jimmy Hu. Feel free to reach out if you have any questions, concerns, or any thoughts on follow-up. Take care.